I now have the questions in front of me. So I will toss some questions to you guys. Sungmin, this is hard. What for EPOs, what parameter for hypertension would you hold the drug? That's kind of a sneaky one. What do you think?
That's actually hard. Of course, you want to monitor the blood pressure, but you're supposed to, hold it for hypertension, but I generally am okay with, I look at their blood pressure. It's really hard because when they come to your visit, their blood pressure may be artificially elevated. So I generally give it unless they're above systolic 160 or something like that, even if they're elevated, because it's so hard to track. And perhaps the better thing is for them to keep track of their blood pressure at home.
Yeah, I really agree with that too. I honestly, after waiting in our waiting room, most people have a 4-digit blood pressure when they're coming in. So, it's really hard to track that in the office. And I think if there is a concern, having a machine at home, I just learned this actually in having an episode with some home monitoring that was going on in my house also, that these home machines, note to self, they're actually calibrated for one arm or the other, and they're mostly supposed to be done on the left arm. Who knew? So I was getting all of these thinking that my poor family member was massively hypotensive, and who knew you're not supposed to use this one on the right arm. So just note to self and for patients for checking at home. But I agree with you that if you have persistent systolics that are elevated, and certainly if the patient has a history of TIA or has other risk factors, then you may want to, you really may want to hold it. I can't remember in the last 20 years when I've had to hold an ESA and an MDS patient for hypertension, though honestly, I don't remember a patient like that. I think we answered the second one, that do we still consider ESAs for low risk MDS? I think the answer is definitely yes. And you made that point that it's still frontline therapy. Another question was, in patients with MDS with deletion 5q started on lenalidomide, do we use aspirin or anticoagulation for venous thromboembolism prophylaxis, especially if they're on concurrent ESAs, or is VTE not as common in this population as in myeloma? So I don't know, Ellen, I'll toss that one to you.
I actually have had a couple of 90-year-old patients who have had PEs on lenalidomide. So I'm pretty vigilant about this. If their platelet count, is adequate, then I will consider giving them a low-dose aspirin, during the treatment for lenalidomide. If their platelet count is not adequate, if it's low, then of course aspirin is really contraindicated and we don't use that. But I think it's a very tricky question. And, I think that, the two older patients can surprise you. They have many risk factors for thrombotic disease. And you really have to look carefully at your individual patient, your patient with diabetes and heart failure who has MDS and who has paroxysmal AFib, may be resolved, but you're dealing with that kind of patient. You really have to be, vigilant about their risk for thrombosis.
Also, I think lenalidomide can be myelosuppressive, so I think it's very important to monitor them very closely when you start them, because if I've had patients that they drop their platelets significantly, so you want to monitor them closely.
I think that's a critical point, and the author of the question is quite right that in the myeloma population, I do think the risk is generally higher in those patients who are started on aspirin, typically right out of the gate. If you have a deletion 5 patient in particular, these patients on lenalidomide, often actually it was said when the drug first came out that if you had a really dramatic lowering of the platelet count, that would often potentially be indicative of drug response. And yet, from 300,000 platelets to 20 in the first week, that doesn't mean you should, that the therapy isn't working. In fact, it could be the opposite. It means that it's working. But I would say that starting deletion 5q patients out of the gate on aspirin may not be a great idea. You may want to wait until they get stabilized on the dose. That said, there are other groups, things like RARST, for example, which can be a difficult group to treat, but for which lenalidomide is sometimes used. I think sometimes in those patients where they have maybe 600,000 or 700,000 platelets, maybe a low dose aspirin to kick off might be something to consider. So another question for Sung-Min was any experience with the oral decitabine, cedauridine with MDS-MPN overlap, which is obviously a difficult zone of disease. What do you think?
I mean, that's very, I guess for MDS-MPN, generally advocate clinical trials, but the oral decitabine was studied in CMML patients with MDS-MPN, and there's data for IV intravenous decitabine. So outside of clinical trials, I think it's certainly reasonable to try where you would normally try hypomethylating agents to certainly try the oral decitabine.
I mean, I think the study that's out is basically saying that from a side effect perspective and an efficacy perspective, you could expect the same with the oral as with decitabine. So it's allowing that sort of concept of a substitution. And I don't know that there would be reason to expect that it's better, but if you were thinking of decitabine in that patient and the patient had access to the oral, that would be something to consider. A couple more questions. Are we using luspatercept in MDS subtypes besides RS? I would say yes, but go ahead and Sung-Min, if you want to answer that. I mean, I think what the author is meaning that if you don't have ring sideroblasts, so I think that's where you dance into a little bit of what's on the label versus off.
I mean, I think it's difficult. Again, I advocate clinical trials. There may be trials with Imedex, for example. There's clinical trials to consider. But outside, there was activity in luspatercept in non-ring sideroblast population, about 40%. But the problem is that you may not get insurance approval, of course. When I've started a few patients on luspatercept, the insurance questions were actually very detailed. They asked if you had ring sideroblasts, what percentage, SF3B1 mutation. So insurance may be a barrier to using it off-label.
So we have a case, a brief one for Dr. Cortez. I'm going to ask the question, but I'm just going to open with the caveat that obviously none of us wants to be giving any medical management suggestions for cases. We don't have enough details, and all of the disclaimers that for the author of the question, please contact for further information. But I'm going to read the question, which is, I would like an opinion on my clinical case, Dr. Cortez. It is a woman in CML in acute phase. She is very pancytopenic, but bone marrow full of blasts. How do I manage ponatinib with her? How long do I expect to have an answer? Does growth factor have any help associated with ponatinib? And she has a donor. So I'll let you, again, with all my caveats that we are not managing patients on Zoom at the moment.
Certainly, and I would echo those caveats, but with that, I would say that most likely the patient's pancytopenic because of the blast phase. So I would start with ponatinib. If that's what you decide that the patient benefits, we don't know the history. So, but ponatinib certainly it's a good choice in blast phase, and I would start with 45 milligrams. We have done recently a randomized study of the three different doses, 45, 30, and 15. The study was, of course, in chronic phase, so I'm extrapolating. But in that study, it showed that the efficacy is significantly better with the 45 milligrams compared to the 30 and the 15. And the risk for the arteriocclusive events, granted this is an interim analysis, so we need to see more follow-up. But again, considering that this is a blast phase, the stakes are much higher from the disease in a patient like this. So I would go with 45 milligrams. And usually I don't stop because of cytopenias, at least not in the first 28 days. Until you get a response, you're not going to get those cytopenias to get better. Support prophylactic antimicrobials, transfusions, whatever you need to do, but continue the ponatinib. And the answer, keep in mind here, your answer is a hematologic response. If I get a hematologic response, start getting the patient prepared for a transplant, look for the donor, all of that. Once I get a hematologic response, these patients should be transplanted. Forget about MMRs and DMRs and all these MRs. once the patient gets to a hematologic response, if you're ready for the transplant, move. If you're not ready, keep going, of course. But no question, the patient would do better if there's less residual disease. But sometimes trying to aim for that, you go backwards. I mean, blast phase, that's a problem when you just go with TKIs, they lose the response. So it's not a given that you're going to improve your response beyond the hematologic response.
Thank you so much for that answer. And now another magical screen event will happen, and we will go to the polling questions to have a look at what happens sort of from beginning to end. So the orange is going to be the pre-session results. The white is post-session results. And the first question was, which of the following is the most commonly used prognostic classification system in MDS and stratifies risk based on disease cytogenetics, bone marrow blasts, and cytopenias? And we can see that the winner initially and subsequently was the IPSSR. And I think that that is certainly the winner at the moment, but I think we all just wanted to highlight the efforts that are going into further incorporation of mutational data into risk stratification in MDS. And hopefully there's going to be a different answer to this question going forward. Then there's going to be a next slide, which is appearing. So which of the following could be considered a benefit of second generation TKIs? So the winner before and after from going from 68% to 85% or deeper responses. So again, I think that was just important to emphasize from Dr. Cortez's talk that there are, that's kind of one of the great things that we saw with the TKIs was deeper responses, and I think he highlighted in a nice table some of the other benefits. Next slide. Okay, so in July 2020, the FDA approved the oral combination of decitabine and cedauridine for patients with which of the following indications? So in the pre-session intermediate, so this is interesting. So the pre-session said intermediate to high risk MDS, and then that dropped down, and then low risk MDS got in the post-session. So that's interesting. So there is some confusion about that, and I can understand where that would come from. Sungmin, I don't know if we can have
this was not the intention of my talk. Oral decitabine was studying mainly higher risk MDS patients, but then the reason I included this in my talk was because they did include patients with intermediate 1, and there were some patients who had intermediate 1 where you can classify some intermediate 1 patients as having lower risk MDS. So that's why I included it in my talk. But for the most part, it's mainly used in higher risk MDS patients.
Yeah, it's actually a slightly confusing when you look at the label. The label actually continues to refer both to the FAB subtypes and to the IPSSR. And that's so when it says RA, RARS, and then it says intermediate 1, intermediate 2, I can understand why this was a pause for a minute, because technically there is an and in the label that could be confusing. It says FAB subtypes RA, RARS, RAEB, CMML, and IPSSR. And sort of depending on how strict your grammar rules are, I can understand the confusion. But thank you for clarifying. And I think there was one other question, or no? That was the last question. Great. So in that case, we are at 11:57, which makes me exactly on time, which is exceptionally rare in all other aspects of my life. But we will now take a break. During the break, you can visit the virtual exhibit hall and earn points for Engage at LLNM Congress contest. Remember to sign up for the Fellows Workshop on Thursday, October 22nd at 6 p.m. if you're a fellow or a resident. You do need to indicate during registration or modify your registration to include this workshop, since we'll be gating it and capping it at 30 registrants. Please contact the help desk if you need assistance. And please come back at 12:20 p.m. when I will introduce Session 3 AML.